Let's talk about the clinical presentation. So the epigastric abdominal or left upper quadrant pain in 90% of patients, only half of those patients present with band-like pain radiating to the back, which is the classic descriptor, and 10% of them will be pain-free. 10% of all presentations will be free. So half of the 90% will not have the classic presentation. And the rest of the patients will be pain-free. Now, the pain-free patients are actually worrisome because epidemiologically speaking, those might be due to analgesic use, steroid use. They might be drug abusers with altered mental status. They may be immunocompromised on anti-inflammatory medications. The mental status may be secondary to ICU or post-operative state, or even pancreatitis leading to this or that, and then you have evolution of the clinical picture. So therefore, check amylase and lipase in any unexplained shock, because as we said, the inflammation of the pancreas causes pooling and edema. It causes severe edema and pooling of fluids around the pancreas in that area of the abdomen. 90% of patients will have nausea and vomiting, abdominal tenderness and guarding, decreased bowel sounds, and that kind of looks like acute abdomen, doesn't it? And jaundice if biliary obstruction occurs, and we already know that gallstones cause 40% of cases, as we mentioned earlier. So within the first week, possibility of systemic inflammatory response syndrome is there, plus minus other organ failure. So that is really important and critical. And if it is lasting more than 1 week, then local complications can start to occur in the area. Everything from mechanical obstruction to autodigestion to infection, and even necrosis, localization, encapsulation, etc. We'll talk about that in a bit. Okay, so look at this differential diagnosis. The differential diagnosis of acute pancreatitis include acute cholecystitis, so that can be a surgical emergency. Perforated viscous, again, medical surgical emergency, and spontaneous bacterial overgrowth. Mesenteric ischemia, again, interventional or surgical emergency. Inferior myocardial infarction, again, medical emergency. Abdominal aortic aneurysm leak, medical surgical emergency. Distal aortic dissection, medical surgical emergency. Ruptured ectopic pregnancy, surgical emergency. So the differential of acute pancreatitis is a very serious one. Diagnostic studies, so the American Journal of Gastroenterology suggests that we require 2 of 3 to label acute pancreatitis. Abdominal pain, lipase or amylase above 3 times the upper reference limit, and 3 would be imaging. So any 2 of those is enough. For laboratory investigations, levels of amylase and lipase do not correlate with severity. They help you diagnose, but they do not correlate with severity. That's something that we used to think in the past. Increment of amylase rise within hours, normalizes within 3 to 5 days. It's faster. This is the one with a shorter half-life. We can have false negative in 20% of patients, including those with ethanol. They may have been using alcohol for a long time. They already have a component of pancreatic destruction, and therefore they do not manifest as much enzymes because they're lacking the ability to make as much enzymes. And hypertriglyceridemia in 50% of patients will also have false negative, but not because they don't have an enzyme. It's rather because the hypertriglyceridemia interferes with the assay of the amylase. The false positive can be in other abdominal or salivary gland pathology, acidemia, decreased GFR, macroamylasemia, so that's another condition in which you have high levels of amylase in the blood. For lipase, it has a longer half-life than amylase, and you need it to be, again, more than 3 times the upper limit of normal. It's 99% sensitive, so it's excellent to ruling out. It's also 99% specific, so it's excellent to diagnose acute pancreatitis. More than 10,000 has 80% positive predictive value for biliary diagnosis. It's a very high number, and it's almost predictive, or it's coming very close to being diagnostic of having a biliary obstruction, biliary pathology. And it also 99% negative predictive value for ethanol use if it is really high. So it's negative predictive for ethanol. So those labs can be really useful. They can have false positive, so it's not only amylase that can have false positive and negative. Lipase can also be false positive in renal failure. In other abdominal processes, other inflammations in the abdomen, acute abdomen, for example. DKA, human immunodeficiency virus, and macrolipemia as well. ALT, you need it to be, again, 3 times the upper limit of normal and has 95% positive predictive value for gallstone pancreatitis. So we have a lot of tools to diagnose our most common cause of pancreatitis, which also happens to be a very serious cause. The imaging studies that we can use, abdominal ultrasound, which typically is not useful to visualize the pancreas because of the bowel gas, which obscures the picture. And the enemy of ultrasound is gas and bone. Those have very different densities, and ultrasound is programmed to respond to the echo, that means the reflection of ultrasonic waves against water-like compositions. So if you have too much gas, you have a bad picture, but it should be ordered. Ultrasound should be ordered for all patients to rule out biliary etiology. Well, we cannot visualize the pancreas all that well. We might be able to, that's one, but the benefit here is it can rule out biliary etiology such as gallstones and bile duct dilatation. And we know that gallstones are our most common cause, or one of the most common causes globally. It's the most common cause in the United States. Abdominal computed tomography is not recommended for initial evaluation unless the diagnosis is unclear, because you know the patient is arrived, and you know that this is a vicious cycle of inflammation. You know that they can still have a shock component, and they might even have AKI or are about to develop it, and you know they're about to go in volume depletion because of the edema and they need aggressive IV resuscitation, and the CT abdomen needs IV contrast, and the contrast is an issue. So for CT, if the pain is persistent and or clinical deterioration after 48 to 72 hours is unclear, then you use contrast CT to rule out local complications, including necrosis, fluid collection, etc. So you diagnose clinically, as we said, and then you use CT to rule out the complications. MRI and magnetic resonance cholangiopancreatography can detect necrosis because they can visualize soft tissue very well, and also used to assess for stones and ductal disruptions. Remember, stones can have similar lucency to some soft tissue depending on their compositions. Gallstones are pretty well, very well seen, even the smaller ones, if they are not moving on magnetic resonance and MRCP, especially MRCP. Endoscopic ultrasound is useful for occult biliary disease. We call that microlithiasis. The severity is defined by presence of organ failure. So you look for acute kidney injury, respiratory failure, GI bleed, shock, and local or systemic complications such as pancreatic necrosis, fluid collections, gastric outlet obstruction, splenic and portal vein thrombosis. So those are the hallmarks. That's the idea that gives us how severe a patient. And we're trying to do, according to the Gut Journal, we're trying to classify the patients in mild, moderate, and severe. For mild patients, luckily it's 80% of the causes where there's no end organ failure or local systemic complications. And once there is no failure or complications, then the mortality becomes lower. But for the moderate one, you can have a transient that's less than 2-day organ failure with local or systemic complications. And although it's moderate, it still has a high toll of morbidity. And if it is severe, it'll have high mortality. And severe means more than 48-hour organ failure, because the more time the organ has failed, the less likely it is to recover. So for prognosis, we have multiple tools such as Ranson's Apache 2 tool, which predicts severity at 48 hours using multiple physiologic criteria such as your age and some of your labs, LDH, your glucose at admission, and at 48 hours, and it looks at dynamic changes like drop in hematocrit, BUN, which is a good marker for dehydration. Blood urine nitrogen is a good marker for dehydration. And if we said massive inflammation in an area where fluid can easily collect in the retroperitoneum, means that a potential of shock and you need a lot of hydration, then lack of hydration is one of your main precipitants of systemic shock and therefore severity, because we already know that severity is related to end organ damage. So you also have the BISAP score, which is a very simple 5-point scoring system. If you have blood urine nitrogen above 25, impaired MS or systemic immune response syndrome, then you have that. So you look at the patient's mental status at the Glasgow Coma scale, Glasgow Coma score. If it is less than 15, even 1 point gives you a 1 point on the BISAP score. And systemic inflammatory response syndrome, age being high, pleural effusion, and it's used within the first 24 hours, so that's an advantage over the Ranson score. And the score more or equal to 3 predicts higher risk of organ failure. And the more risk of organ failure you have, the more risk for mortality. The CTSI is a CT scoring. It's a computed tomography severity index, and it gathers CT data at 48 and 72 hours, and it looks at fluid collection, necrosis to predict mortality. So that's the CTSI. For treatment, fluid resuscitations vary aggressively in the first 24 hours, even if it is mild. So we're going to go for 20 ml per kg, IV boluses, and that's going to be something like 3 ml per kg per hour. The goal is to decrease blood urea nitrogen hematocrit concentration over 12 to 24 hours. These are both good markers for dehydration. And you need to keep checking for urine output, which is the first thing to be deranged in acute kidney impairment. Lactated ringer may be used instead of normal saline because it decreases systemic inflammatory response syndrome, and you want to avoid it if the patient is hypercalcemic, because this can cause saponification of the fatty tissue in the pancreatic area. Is full of fat and it's being digested and inflamed in that area of the abdomen. So for non-pharmacologic, especially nutrition, supportive care, and adjunct treatment, underlying cause treatment, there are additional special consideration. While we said restrict oral intake initially, early enteral feeding the moment you start controlling inflammation is encouraged. It's not superior to feeding at 72 hours, but you don't want to withhold it much more than that without a clear indication. For mild cases, you want to start feeding once the patient has no nausea or vomiting and no ileus, the pain has subsided. Even if the pain is not completely gone, you can start low fat, low residue, like soft diet. And that is actually as safe as liquid diet and is associated with a shorter length of stay in the hospital. For severe cases, early introduction of food is defined as within 48 to 72 hours. Enteral nutrition indicated and preferred over TPN, where in the past we used to introduce strictly after 72 hours. And this decreases infections, complications, organ failure, surgical interventions, and mortality. Give analgesia to patients and opt for IV opioids in the severe pain phase and in the initial phase. Then monitor respiratory status and adjust doses if you have renal impairment. Ask for help from your clinical pharmacologist or senior if you don't know how to do that. But you want to opt for IV opioids. Remember, pain actually contributes to inflammation, and usually a lot of people don't take pain seriously. This is one of those conditions where you should. Gallstone pancreatitis needs urgent intervention in certain cases. So the urgent intervention is defined as the need for intervention within 24 hours. And ERCP, endoscopic retrograde cholangiopancreatography, and intervention sphincterotomy is needed if there's cholangitis, sepsis, or total bilirubin of more than 5. If mild, cholecystectomy during initial hospitalization to decrease risk of recurrence can be done. So that's based on the 2015 article in The Lancet. And you can defer surgery of necrotizing pancreatitis until the condition has improved and there's no more inflammation and fluid collection. So you don't want to go in a surgery and have higher risk of inflammation in your surgical field and therefore higher risk of complication and infection and so on. Furthermore, for hypertriglyceridemic patients, so we said those patients you want to go aggressive. So you can give insulin infusion, continuous infusion, and you can give dextrose as needed to prevent hypoglycemia and monitor the potassium and replace as necessary. What it does is activates lipoprotein lipase, and that decreases the triglycerides in the blood. You want to give fibrates with that, which is one of your antilipid agents, plus minus plasma apheresis. If you're not getting good control, go ahead and do apheresis to get rid of the extra fat. There is no role of prophylactic antibiotic in the absence of infectious complications, as per the 2012 article in the World Journal of Gastroenterology. The complications of acute pancreatitis can be divided as such: systemic, which include ARDS, abdominal compartment syndrome, acute kidney injury, gastrointestinal bleed, pseudoaneurysm, and diffuse intravascular coagulation because you have severe inflammation and that leads to an immune system going berserk. Metabolic, hypocalcemia because it's being used in the saponification of fat. Hypoglycemia because you're having inability to process and digest food, and hypertriglyceridemia as well. Fluid collection can occur, and it can occur in acute collection seen in early phase, but it's not encapsulated, and that usually resolves within weeks, so you can wait and observe. And some patients will have a pseudocyst within a month or 4 weeks after initial attack, and that causes an encapsulation of fluid. You don't need to treat that if the patient is asymptomatic, regardless of the size or location. But if symptomatic, endoscopically if possible, otherwise percutaneous or surgical drainage. For pancreatic necrosis, a non-viable pancreatic tissue, you want to do a CT-guided FNA if an infection is suspected. So if there is no infection, we call that sterile necrosis. If asymptomatic, it can be managed expectantly, and there's no role of prophylactic antibiotics. So for infected necrosis, 5% of all cases, 30% of severe high mortality. The treatment in that case would be carbapenems, metronidazole, and fluoroquinolones. And if the patient is stable, you can defer drainage to more than 4 weeks. That allows liquefaction and a walled-off pancreatic necrosis. We call that WOPN. If symptomatic or unstable, percutaneous drainage and minimally invasive drug debridement or endoscopic necrosectomy can be done. For walled-off pancreatic necrosis, fibrous wall surrounds necrosis over, weeks, and endoscopic or pancreatic drainage is, in that case, preferred over open necrosectomy, and we do that if infected or symptomatic. Otherwise, we continue to observe and monitor. I hope this was useful.